Hello and welcome to ESC Cardio Talk. My name is Adrian Banning and I'm Professor of Interventional Cardiology at Oxford University Hospitals, Oxford in the UK and England. And I'm with Gianluigi Di Maria, my colleague here in Oxford. And we're going to discuss today the paper in the European Heart Journal, Continuous Thermodilution to Assess Absolute Flow and Microvascular Resistance Validation in Humans using 150 H2O PET. This is a study that we've written an accompanying editorial about in the European Heart Journal. And I'm going to start off by asking Jan, why should we worry about microvascular dysfunction, Jan? Why is it something that's of relevance to our clinical colleagues?
Thanks for this question. Actually, this is definitely a very hot topic, and there are plenty of papers and manuscripts that we can see across literature in the last couple of years. As a matter of fact, understanding how the coronary microvasculature works is still something that needs to be investigated. I mean, our understanding of the phenomenon is very partial, is not complete. The reason why we should understand microvascular dysfunction is that it's becoming an area where actually this could be an easy target for future treatment, and that's why we do believe that increasing the amount of knowledge on this topic is extremely relevant.
So we're not talking about the stenotic lesion here. We're talking about the microvasculature beyond the coronary arteries, the sort of web, the leash of vessels that supply the actual myocardium itself.
That is right, and we can probably come to the conclusion that in 2019, as interventional cardiologists, we have become quite proficient and effective in treating epicardial coronary artery disease. But we can still see that as in specific settings, and we can discuss about that, we can see that actually our intervention is partial in terms of outcomes. And we do feel the need of further improvement, and we do understand that the black box that we are clearly not addressing specifically is exactly the coronary microvasculature.
So we can end up with a good result in our coronary artery, but there may still be problems within the vasculature beyond. So clearly perhaps there are two real settings, aren't there, where we might see issues here. The first is those patients who do not have obstructive disease, who have chest pain, which sounds like angina, may have inducible ischemia on non-invasive testing. And for many years, they've been very difficult for us to understand and treat. The second area I think that you and I have been particularly interested in is in the setting of acute myocardial infarction, where we open up the obstructive lesion, we put in our stent, but the flow is still poor. And that's down to impaired function downstream. Now, you've done a lot of work in this area. You've used pressure wire to investigate that. Talk us through a little bit some of the work that you've done, which shows why we get slow flow or no flow following successful opening of the vessel.
Yeah, this is indeed one of the main issues, especially when you're treating patients with ST elevation myocardial infarction. As we know, slow flow, no reflow is something that can happen. The incidence of this phenomenon is very variable according to the techniques that you're going to use. The rate can go up to 40%, so it can be quite common experience in the cath lab. We do know that there is a certain proportion of patients that actually will recover no matter what you do, but there is another good, let's say, chunk of them that pretty much require something extra to be done. The mechanism involved in this phenomenon are, of course, different, and they can go from distal embolization to ischemia reperfusion injury and individual patient, let's say, susceptibility for this. The point is, it is important to understand who are the patients that will require something extra. And the earlier we can identify them, the earlier we can, of course, consider additional or alternative treatment for this in this regard. But coming back to the point of why we need to assess microvascular dysfunction, the other point is actually also those patients that come to the cath lab with apparently an acute coronary syndrome with chest pain, troponin elevation. The ECG might be a bit borderline. Then you do the coronary angiograms and there is much nothing there. And they are always a problem because you really don't know how to label them. So if we could have a tool that can tell us that the problem is actually microvascular dysfunction or injury, actually that might help us to, first of all, from let's say an academic interest, at least give a diagnosis to our patients. And second of all, of course, the moment that we know what is the mechanism behind, we can actually address it specifically with medications.
So that group you're referring to have been coined MINOCA.
That's right.
MI with normal, non-obstructive coronary arteries. So to understand that, we need to measure absolute flow, and we need to understand microvascular resistance, and that's what this paper is all about. And Paul Knappen and his colleagues in Holland have looked at this new technique to measure absolute flow. Do you want to just talk us through how that technique works, Jan?
Yes, I think this piece of work can be a cornerstone in understanding of coronary microvasculature, but probably in general, coronary physiology, I think. The point is, until today, we have always relied on measurements of surrogate of coronary flow and coronary resistance. And this is because until today, we could not measure absolute coronary flow. So we always had to rely to flow velocity using a Doppler wire, or to pressure-derived measurements using a standard pressure wire. For the first time here, what we can see and read is about a new technique that essentially can provide us a unique measurement of flow and resistance. This technique essentially is based on the combination of a standard pressure wire with a temperature sensor at the distal end and a dedicated microcatheter that allow a slow and constant infusion of room temperature saline. So from the methodological point of view, and this has already been shown and demonstrated in other manuscripts by the same authors and eventually confirmed in this one, the first point to be aware of is that they can show that it is possible to achieve maximal hyperemia through a constant infusion of room temperature saline. So when we compare these measurements taken in this way with adenosine, so with standard, let's say, induced pharmacological hyperemia, we can realize essentially that the measurements that we get are pretty much consistent. So that's the first main observation.
So we don't need to use adenosine for this technique.
That's
the
right.
saline causes the vasodilatation that we measure.
That's right.
And this is building on work from Nico Pils and Bernard de Bruyne, who've been looking at this technique for some years, really, with this new catheter. It means that in the cath lab, we are now able to measure absolute flow. In the past, we could only have done that with a dedicated cardiac PET scanner, and because we're not able to do that.
That's correct.
And I think one of the issues has always been about the variability of the tests, particularly in the group of patients with unobstructed coronary arteries. Some ischemia detected on one perfusion modality, but not on another perfusion modality. And not really knowing which... that lack of consistency, I think, really made understanding the pathophysiology really very difficult.
That's right. And the second element that you need to do this kind of measurement is, of course, it does remain a pressure wire. So what we are looking here is still is a thermodilution technique, and in terms of how you're going to do that, pretty much you will deliver your pressure wire beyond your lesion. The authors make clear that this should be at least 3 centimeters away from the tip of the microcatheter. And then you start the infusion of the room temperature saline from the microcatheter that is essentially placed, I would say, really just outside your guiding catheter. And by pulling your pressure wire, your thermodilution, your temperature sensor can actually detect the change in temperature, and through a not very complex equation, actually, it's possible to derive absolute flow. The moment that you have flow from flow, you can measure absolute resistance, and pretty much you can have, for the very first time, a direct assessment of flow and resistance using a simple device invasively in the cath lab while you're doing your procedure.
This isn't really to look at the lesion obstruction. We've got that with FFR.
That's right.
This is more to do with the resistance downstream from that lesion, or the resistance downstream within that vessel that does not have a lesion.
Of course.
And that's how we understand this going forward. And in this paper, they essentially compared those invasive measurements with what is essentially state-of-the-art, which is PET.
That's right. And even though we are still looking at the microvasculature, what we can have here is an online measurement of microvascular function that can help you to interpret in a proper way also your FFR when you are assessing your epicardial stenosis. This is again very relevant in patients with intermediate coronary artery disease. If we think, for example, patient with aortic stenosis or some sort of cardiomyopathies where you are uncertain about the function of your coronary macrovasculature, if you can assess the function at the same time, then you can look at your FFR result pretty much in a different way.
So that's really fascinating that we may finally be moving forward. And that was really the theme, I think, in our editorial, wasn't it? That ultimately this consistency of approach between non-invasive tests and invasive tests, I think maybe a big step forward. So perhaps I should ask you, where do you see this data leading us perhaps 5 years down the line? Where do you think this might be? Where will you be using it, do you think, in your clinical practice?
Yes. As today, I think we need to be honest, and we have to look at this tool still as a research tool. So we can't think of a clinical application right now. But I think the potential are tremendous here. And if in 5 years down the line, we can confirm that this technique is definitely viable, is definitely feasible, and is actually superior to the, let's say, surrogate-based indices that we currently have, then I think it can be essentially groundbreaking. It can become the new way to assess coronary macrovasculature on top of epicardial stenosis in pretty much in daily practice.
And that might then allow us to tailor our therapies. So in the field of non-obstructive coronaries with chest pain, which sounds ischemic, we can define an abnormality, we can tailor our therapy to the right patients, and perhaps look to work out which drugs are helpful in reducing symptoms and disease burden. Secondly, in the area that you and I have been particularly interested in STEMI, how we might more objectively measure impaired microvasculature post-intervention or peri-intervention in the way that you and I have been doing it, and then use that information to tailor our therapies so that we actually move away probably from trying to administer the same treatment for every patient, much more towards a single tailored therapy for that individual, which is hopefully going to improve their myocardial function and consequently prognosis.
Absolutely right. I completely agree with that. And I think this can be an extremely good tool to move from our current approach to a sort of personalized therapy, as pretty much is happening in oncology. In cardiology, we need to realize that, for example, we are trying to treat in the same way everyone. And now we can see that this really doesn't work. So if you can identify upstream as early as possible those patients that don't do well with the current treatment, of course they can be early detected, early identified, and we do have already some devices, some therapies, some drugs that can make the difference. And of course we can't provide them to everybody, just because there will be some sort of dilution effect. But if we can identify the right patient up front, then actually that can truly make the difference. And this is important in clinical practice, but also if you're thinking of designing new trials and new studies.
That's a very good point. I think in order to find these new therapies for the patients with unmet need, we need to target our therapies to the right patient and lose the kind of smothering effect of good results in patients who didn't need extra therapies. That's been a really interesting discussion, and thanks, Jan, for your time. So that's the end of this ESC Cardio Talk transmission. Thank you very much.
Bye.